So we'll just give them a minute to do that.
Just trying to share slides with sound, so an extra layer of complexity. Can you see that okay?
Yes, I can see that. That's great.
Fabulous.
We'll just give it another minute. Johnny, are you able to unmute?
Yeah.
Oh, good.
Yes.
I will hand over to you then, Johnny. And
okay. Yeah, okay, hopefully we're all here now across the two Teams links. But yeah, welcome everybody to our second seminar in our Community of Practice series, and the first one with some invited speakers. So welcome to Ruth and Debbie, who have kindly joined us today to talk about meaningful PPI and electronic health record studies. So just a bit of housekeeping before I hand over to them. We're recording this session and we're going to be uploading it to the Leicester website afterwards and also circulating it with everybody. And if everyone can keep their cameras and mics off while Ruth and Debbie are talking, that would be really helpful. And if anyone does have any questions as we're going along, feel free to stick them in the chat and we'll monitor that, or wait until the end and raise your hand and we can go through them that way. But thanks everyone, and over to Ruth and Debbie.
Thank you very much. Yes, thank you for inviting us to come and talk to you about PPIE and electronic health record studies. So my name is Ruth Jack. I'm a Senior Research Fellow at the University of Nottingham. I'm an epidemiologist by background, so working on large electronic health records, databases, cancer registry, primary care, hospital episode statistics, that sort of thing for a number of years now. Pass over to Debbie.
Hi everybody, my name's Debbie. I've done a lot of work with the university around PPI, and I've been doing it for 25 years now, so I'm a bit of a dab hand at it, I think. But I'm here today to sort of talk about how Ruth and I have gone through the studies and in partnership and how I can get involved.
Thanks. So hopefully if we move on to the next slide, there we go. So just briefly what we mean by electronic health record databases. So these are essentially health information that are in large databases usually. They're often routinely collected information such as primary healthcare records or registry data. And often these are collected for healthcare delivery, healthcare administration or billing, or for previous studies even. But the main point of them is that the research that we're doing is a secondary use of the data. So we haven't been involved in that primary data collection. So the sort of information that's often included in these databases, prescriptions, so exactly what medicine, what brand, what strength was prescribed, when it was prescribed. Sometimes you get dosage and how many days they were prescribed for. Any referrals to maybe secondary or tertiary care, vaccination history. Probably the biggest one that we tend to use are diagnoses and symptoms, and depending on the system that you're looking at, the database you're using, they can be coded in a variety of different ways. Laboratory tests and results that have been ordered and received, and demographic data. Now, usually the databases that we can access have been anonymised in some form, so you will often get sort of more anonymised information. So you might get sex, but you'd only get year of birth rather than date of birth or specific age related to an event. But you would get things like region that the person lives in, and sometimes extra information, which I'll talk about here. So these data sets that we tend to use are often linked to other ones. So you might get primary care data from GP practices, and that could be linked to hospital data. So hospital episode statistics tend to come in three different blocks. There's the admitted patient care, outpatient information, accident and emergency. And then these records are often linked to what we call small area data, which is usually a way of describing the deprivation of the area that the person lives in, but you can also get like rural and urban status, that sort of information as well. There are imaging data sets, death data from the Office for National Statistics, which would give you a sort of official date of death and cause of death information. Obviously, more recently, there have been COVID-19 data sets with positive test results and vaccination history. And as I say, there's also cancer registry data, which is often linked to these data sets and quite comprehensive.
Yeah, we looked at the database, and coming from a non-skilled position, I found it really difficult at times. But the information about larger numbers of people over a long period, it's good to use to do that. There's a wide range of information collected, and I think during when we were looking at this, some other members of the PPI group that were involved in the study talked about, do we like the idea that GPs are recording all this information, because it can be quite scary because you don't know exactly what they're recording of you, but also it can be the other way around. And if we were told about that, then it might make us feel a bit more positive that things are being recorded. The advantage of a large database as well, we don't have to wait for the data to be collected. I've done a lot of work on qualitative research where we look at different people's stories and how they manage their life, basically with maybe multiple health conditions. And the information is collected as it happens. Moving on to the disadvantages that we found. We don't get people's stories. I found it really difficult when Ruth and I first started to work together. Why don't we get people's stories? Because, you know, you can gain so much rich information from people's stories. But I've learned that's been one of the biggest learning curves for me, I think, is understanding the difference in the two types of research. The disadvantage, again, complicated data analysis. Now, as a lay member of the study team, I have no idea how that happened. I have no idea how a computer program would work all that out. But that, I think that for us was probably the only bit that once the data had been put in, once the coding had put into the computer and the computer was doing its job, then I was quite happy to sit backwards and wait for it to do the work. A large database can't answer questions if the right information hasn't been collected, which is what we all work with these days, a lot of technology around what's recorded and what's not. And also there may be missing information because the database only will have what the doctor puts in. It won't have a lot of other information.
So I thought a useful way of talking about some of the work that we've done is from a particular database that we tend to use most often, called the Clinical Practice Research Data Link, or CPRD. So this is a primary care database, and it has two data sets available within that. So as you can see, the Gold database currently has around 2.6 million registered research acceptable patients, which is about 4% of the UK population. And at the moment, that's exclusively data from Scotland, Wales and Northern Ireland. And the Aurum database, which is exclusively English data at the moment, has 16.7 million people, or just about a quarter of the UK population. But if you include the sort of historical records that they both have, there's 21.6 million people in the Gold database and 50.6 million in the Aurum database. These are obviously very large databases. If you want to access the data from CPRD, you need to have a protocol approved by their expert review committees. And as part of this, there is a patient or user group involvement section. And recently they've sort of tightened the word limits on lots of the different sections. So you have 150 words to put how you're going to involve patients or user groups. And although that involvement isn't mandatory, you do need a strong justification as to why you're not considering it. So the way it's sometimes been phrased is involving patients or public isn't mandatory. It is mandatory that you've thought about it and justified why you're not doing this. So some of the exceptions might be if you're doing research that requires an urgent response because there's a serious public health or other concern, for example, COVID-19, when that was when we were able to use data to try and answer some questions around that. If there are ministerial requests or there's an urgent drug safety issue or there's been research requested by law. So the guidance that the reviewers get in terms of looking at the applications is that the PPIE should add value to the research. So it should improve the transparency of communication of the proposed research. It should inform better conduct of the research or wider dissemination of the results. But there's also an understanding that it should be proportionate to the research. So it should be relatively easy to organise and arrange, should be timely and cost effective. So if you are doing quite a small study, you're not expected to set up a lived experience advisory panel that meets twice a month for a year or something like that.
Yeah, just a few practical suggestions that Ruth and I worked on. And I think when we first met, we were both a bit, how do we work together? So we developed several ways of working, one of which was to review the lay summary explaining your research. So more often than not, I would read the lay summary, and make any comments. But this can be difficult for people to do, depending on the language. And although it's a lay summary, then obviously with quantitative research, the language is quite difficult. So in reading the lay summary is always a good place to start. So patient involvement in grants and other funding application. It's always good to have PPI involved. And I think from my experience working with academics, I think it's really interesting how different academics approach this and about how if we work together, we can make a common line and work through the funding application. It's very difficult because I think Ruth mentioned earlier, the word counts often are very short. So trying to develop a lay summary in 150 words is never very easy. Yeah, including patient partners in the research team as co-investigators. Now, I was involved in quite a lot of research, both here and across the university, as a co-investigator, and I've learned so much, and I think using that experience has enabled me to work even more deeply with researchers into the studies that they're performing. Yeah, in study advisory groups, they often appear. It's always good to have people like myself on the advisory group, so or the management group. Various names are come across when people are getting groups together. They worked very well at the beginning. A lot of the information went straight over my head, but as time goes on, Ruth and I and the other members of the PPI group would meet separately and talk about any questions that we had regarding the advisory group meetings. It's always good. There are out in the community, there are lots of different groups existing that sometimes we never hear about, sometimes we would like to hear about, but how do we communicate with them? There are different groups. I have celiac disease, so I'm a member of Celiac UK, so there are lots of different groups around looking at celiac disease, things like that. And you'd be surprised how much existing groups actually can offer to the study. We can often host workshops and focus groups with local patient groups as well to describe the concept of work and elicit feedback. We've developed that within the PPI group, within our research, we've developed that good working relationship with the focus group.
So just to say, these are all practical suggestions that come in the CPRD application guidance. So these are ways where they're trying to, because still I'm a reviewer for CPRD, and still you sometimes get people just filling out, we're not recruiting any patients, so PPIE is not relevant. So they're trying to give these, sort of concrete examples of how you can actually involve the patient and public communities in the work.
Absolutely, yeah. Being involved. Now, there were lots of questions for myself, actually, when I first started to get involved in quantitative research. It was about what can I contribute, because I basically understood that databases were big items of information, but what was my role going to be within the group, and what my role was going to be within the research. So that was one of the biggest questions. And it might be that you have a lot of people ask, what is it that you want from me? Because as well, it's what I want from the researchers, because we have to work together. So finding that common ground again needs to be done right at the very beginning. Yeah, I've been involved, like I said earlier, in a lot of qualitative research, mainly around mental health. And it's good to get people's stories, but obviously within quantitative, that's not the way that it works. Again, what was my relevance to the story and the research? Just to give a bit of background, I've had health problems all of my life, along with mental health problems after I had my daughter. But I wasn't sure what relevance I had within the study. But there were things that happened, which I'll allude to later. Right at the beginning, again, building relationships. I think I mentioned that it's good to build a relationship with a research study, with the members of the team, and really work together. And I think it can be difficult at times. You, as researchers, I'm sure you have questions that you find difficult to answer for PPI members, but it's about being open and transparent about what you can do and what you can't do. And again, from my point of view, I have to be open and transparent about what I can do and what I do and what I don't understand. Joint learning, I think I've alluded to that already. We've learned a lot from each other in the group, and I think it's been really good. So, not afraid to ask questions, not always easy. Right at the very beginning, when I used to go to study meetings, it would just go straight over my head. And I didn't know if the question that I had was relevant. Was it a stupid question? I know there's not such thing as a stupid question, because somebody else in the room probably wanted to ask that question. And so when I did ask it, although at the beginning it was difficult, I am finding it more easy now to ask those questions, which hopefully aren't that stupid. Being involved in the whole process, I think we talked about this earlier again. Analysing and the coding is difficult. So Ruth, one of the research assistants, sent me a list of coding. And I think that email probably still lying deep within my inbox for me to understand. And I don't think I ever will. So my role in the insight I got from this was, it's a large database. GPs recording such information on patients. Is a study relevant? There were studies, part of the study that Ruth and I have been involved in, that I mentioned a bit of my experience, and that changed a bit of what we did in the research as well. Public money, is the research value for money? we spend an awful lot of money on research, but are we researching the right things? And I believe that this research that we've been involved in actually is. People's stories, we keep mentioning that. Part of my story is long-term health conditions, and how I've worked my way through those, and how that can help research. Insight into coding, talked about that already. And then I think the biggest question probably is, what is my role? And just to be there, really, be there and discuss things and try and work out what that actually means. So, yeah.
So I just wanted to pull up these items from a report a couple of years ago from the McPin Foundation that they'd written about research involvement groups. And again, they'd sort of spoken more broadly about what types of activities can research involvement groups work on. And these ones that I've highlighted are probably relevant to every single study of every type of methodology. And so defining or refining the research questions, what are the topics that are important to people? Choosing an appropriate methodology, again, you can have conversations around that and try and get a sense of what you'd be able to answer with different methods. Scoping work, including literature reviews, finding out what's already available on the topic that you're interested in. So all of those at the beginning of the study, and then towards the end of the study, being involved in writing any results up, dissemination, spreading the word about what you've found, and implementation if you've produced anything that fits in that. But quite often, and again, when I started and went to some sort of PPIE training activities, they would often focus on these sorts of elements. So developing data collection tools or generating study materials like consent forms or information sheets for participants, which aren't relevant for electronic health studies. The data sets are already there. And again, the data collection that they've highlighted, which would often be qualitative interviews, that training people up to take part in those sorts of studies is easier and more practical than trying to get people, and people are probably more interested in that than learning statistical coding and large software. But these two that are left, I've sort of highlighted in amber because I think there's an element that can be done and there's an element that can't be done in electronic health record research. So while we don't have participant recruitment, you could have public contributors involved in staff recruitment if you're recruiting new people to join the study. And while, again, as I say, you might not want, public contributors might not want to contribute to analysis, we felt that there was probably space where they could be helped to review the analysis and provide their interpretation in the same way that we often get clinicians to provide their expertise on the analysis that we've done. Lived experience is equally as valid, and getting that insight to what we've done is really important.
You did? Well, once the data had been through the computer, Ruth and myself and other members of the PPI group would meet outside of the general meetings of the research study, and we'd go through the results. And initially, I remember it being in the summertime, and we sat in one of the cafes on campus and was going through them, and we were looking at the graphs that Ruth had presented to us and trying to establish what that actually meant. But it was difficult in the beginning, but it oh, excuse me, sorry. It increased the number of public contributor meetings during the project, which, if funding often should be allocated to that as well, which it was. And I think I benefited from those by having that bit more confidence in a smaller group to actually ask those relevant questions. We looked at the graphs, and initially I had no idea, but Ruth was very good at explaining what they were trying to present.
So what we did was we sort of paired up a PPI meeting with our project meeting. So depending on what was going to be discussed, we'd either have the PPI meeting afterwards, in which case we could sort of go through anything that hadn't made sense during that meeting, or if it was going to be more sort of results focused, then we often meet beforehand so we could go through, and the public contributors had a bit of a heads up and a bit of a more idea about what would be discussed, so that they could contribute within the project meeting with the clinicians and the other project team members.
The meetings, as we've already alluded to, explaining the analysis and the results. And as an introduction to quantitative research, so we've learned an awful lot, and I think we're going to talk about.
Yeah, so what we did, we developed a training course. So it was some sort of PPI managers, public contributors and researchers, all in a group. And we thought this would be a helpful way to sort of, based on this very simple research cycle of identifying research questions, designing the study, sort of actually doing the research, then analysing and interpreting the data and sharing the results, and how that sort of continues. We wanted to focus on how public contributors could be involved in or understand better study design and analysing and interpreting data.
Yeah, the purpose of the training was to enable public contributors to help shape quantitative research from start to finish. So it was also to provide a background knowledge about strengths and limitations of quantitative study design and analysis. Now, that sentence alone says a lot, I think. Quantitative research is very difficult from my point of view. So I think this the whole development of the training enabled more understanding for myself and other members of the group, and then we were actually confident enough to help to deliver it. We delivered it via a network of PPI in health and social care research in the East Midlands, called ShareBank. And I think initially we developed it and we shared it with a group of children and young people, didn't we? Is that the right one?
No,
that was, sorry.
No, so the course that we delivered via ShareBank sort of went to people who, as I say, in the East Midlands had an interest in this sort of research. And so we got a mix of public contributors, but there were a few researchers who took part. So in fact, we ran it over 2 half-day sessions and we had 14 participants in those. And the way we set it up is we delivered it online, which obviously had its advantages in that people could attend from wherever without having to travel. We created a separate workbook which contained copies of the slides that we presented, information around the exercises that were part of the course, and there was also sort of extra information. So if there was this little question mark magnifying glass symbol, that just meant there was more detail in the workbook, because we were very aware that some people were just want to know the very bare minimum, and some people, like Debbie, actually want to sort of understand a bit more, you know, where does this come from, what does it actually mean? So we wanted to cover both of those without losing either of the groups. As I say, we had these breakout group exercises, and this is where being online was less helpful. We had a couple of people sort of lost in cyberspace for a time, but eventually we got to them, and hoping to give them that experience that actually, if you take these things a step at a time, interpreting results is actually fairly straightforward. And we also did sort of quite simple surveys before and afterwards to try and understand people's knowledge coming into the training and what they felt they'd learned afterwards. And overall, there did seem to be better understanding, particularly around the concept of p-values, how adjustment worked, and generally how quantitative analysis worked.
Our public contributors, it was just a small team of us. There were two members to the group initially, and they were based at the university, and we became quite close. It it's always good to have additional public contributors, and we did with a couple of the other questions. We engaged with other contributors who managed to come and work with us as well. The research questions, I think one example would be that we looked at polypharmacy. I talked about people on multiple medications, about how that can affect their health and their mental health. And public contributors were involved in the funding applications, including commenting, including commentating on lay summaries, which I think we talked about earlier, which can be difficult to do. But I think once you get the gist that quantitative is different to qualitative, then that enabled me to move on and understand things a lot easier. The involvement, I've been very lucky. I've been to a couple of conferences where we've talked about our work together, where we've looked at abstract submissions and co-presenting, which we've done a couple of times. The last one being in Bristol, I think it was it?
Coming up, yeah.
Yeah, it was good. So that was interesting weekend. And also I've been, and the other members, a couple of the other members have been co-authors on journal articles.
Yeah. So this is generally how our sort of research area is set up, that we have our sort of core public contributors, and then when we have extra funding, we can recruit additional people to sort of vary the voices that we have helping us in our research. I just wanted to go through an example around a medication reviews project that we did. So as Debbie mentioned, polypharmacy is the sort of main research area that we're looking at, which we're describing as multiple medicines being taken by people at the same time. And so we had discussions with a patient involvement team around this topic and wanted to find out what was of interest, what was concerning to them, so that we could see whether we could translate those into questions that we could answer. So there was generally, the feeling of, well, what can we do about people being asked to take lots of medicines at the same time, and all of the sort of extra brain power that requires if you're having to take one at breakfast, one 2 hours before food, one with meals, all of those sorts of things, which can be quite a burden, never mind the potential adverse outcomes and health effects that might be happening with people taking combinations of 10, 15, 20 different medicines at the same time. So in discussing about that, some of the people mentioned that they had medication reviews to sort of go through what they were taking with their GPs and other health care practitioners, but not everyone did. So one of the questions that came from that is, do people have medication reviews? And do people have equal access to reviews? Are there different groups of people who may be more likely to have a medication review than others? So we got some funding from the NIHR School for Primary Care Research to investigate access to and impact of medication reviews. And as part of this project, we produced a video describing the public contributors' experiences working on this sort of database project. So the 3 public contributors who were involved in the study wrote their own sections of the script, and 2 of them actually recorded their voiceover. Now, if the technology works, I'm hoping we might be able to play that now. Let me know if you can't hear it.
There's a lot of evidence that utilising PPI, or patient and public involvement, in research can help improve and personalise treatment. Our research team recently worked on a project after PPI team members asked how valuable medications reviews are. By looking at anonymised records of over 500,000 patients, we found that just over half of people aged 65 years and over had a medication review recorded in 2019. Of these, only 46% took place face-to-face or over the telephone with the patient. So how did our PPI representatives find the experience?
This project followed a key spirit, encouraging us to ask all important questions, not only to start discussions, but ensure PPI involvement through the different stages of the research.
I discovered that I could bring my unique life experiences to the project. I surprised myself by providing help in a number of ways.
I felt really supported and I was encouraged to speak up when I didn't understand things.
Understanding graphs and tables with lots of figures was quite a challenge for me, but the research team helped explain things in a clear and interesting way.
Together, by taking a more patient-led approach, we can improve people's experiences of healthcare and research.
So with that, we really wanted to really concentrate on the PPI experience of working on the project rather than the results necessarily, and how quantitative research, database research, these sorts of hard to reach research, as we sometimes call them, can benefit from the patient and public voice as well. So as Debbie mentioned, the way that we've worked, we've also had, so this was the paper that came from that, and the highlighted people are our public contributors who were involved in the project as co-authors. And yeah.
This is the Bristol conference that we presented at. I've done quite a lot of presenting, but I did feel quite nervous on that day, and it was a very difficult day, but the fact that we were being able to be heard and understood about what involvement actually means within a study. And I think there were some quite good relevant questions that came from that presentation. And so it's been a real eye-opener the last few years when I've been working with Ruth and the research team.
So I think sort of the benefits of really trying to engage the PPIE throughout the studies. So as well as developing those questions, the stuff at the beginning of the study and the dissemination, the papers and the presentations at the end, sort of having more meetings, and even if, you know, the codes that we sent to Debbie, not for her to go through, but to sort of say, this is why it's taking us ages, because there are 1,000 different codes that we need to identify for this particular outcome or whatever that we're looking at. So just understanding that rather than it being, oh, a depression tick, there's actually, you know, hundreds of codes that could potentially be relevant to our study, and working those out. So getting that understanding of why database electronic health record research can be useful, you know, I think reassuring people that it's not accessing people's data so that it is anonymized, we can't tell who these people are, all these things to sort of try and increase public and patient involvement in these sorts of studies, whereas a lot of the time people are like, oh no, numbers, that's not my thing. I'm happy with the qualitative stuff, but to really try and get that involvement throughout the study, so we don't just speak to them at the beginning and then come back to them a few months later with our results. And that really comes from better communication, that, you know, sort of from those initial meetings where Debbie and I were trying to work out how this could work, when most of the time it's me or somebody just sort of at a computer trying to figure things out, but getting that communication going so that there's better understanding. Asking each other the right questions so that Debbie knows she can ask us a question about the analysis, and I know I can ask her a question about the process and the topics that are important to her and the public contributors, which all makes the research more focused on the issues that matter to the people who are impacted by these topics. As I say, we hope we've improved the confidence in public contributors being involved in sort of more quantitative research, that even if you don't know what these codes mean, it doesn't matter, you know, you can understand the results that we're showing you and what that means, and what, most importantly, what that means to the people affected. And there's that better understanding of the work. So again, from the public contributor side, that they have a bit of a better understanding about how these studies work, and we have a better understanding of how it affects other people. And hopefully that means we've managed to sort of create meaningful involvement that does go throughout the whole length of the project.
Yeah, exactly.
Yeah. So thank you very much for listening. There's our contact details there if there's anything that you'd like to talk to us about, but happy to take any questions.
Thank you so much, both. That was really, really great talk. Very interesting, and really great to hear about some of the practical ways that you got the patient public members recruited as well, because I think that's something that as researchers we're often wondering the finer details about. So that was really useful to hear. So yeah, if anyone does have any questions, please feel free to raise your hand or put them in the chat. And while we're waiting for everyone to do that, maybe I'll kick it off. So I was wondering about the kind of perception that you've had of other people seeing patient and public involvement in this field, because like you mentioned that it's this secondary data analysis that you're doing where the data haven't been collected for that purpose. And I think my naive thoughts are that there are some groups of people that would say patient and public involvement isn't needed for that because it's not the primary data collection and the primary purpose. And I think you've obviously shown the benefits of having this involvement, but have you encountered any of that kind of pushback from anyone or surprised that there was PPI involved in this project?
I mean, I think locally, so we're funded by the Biomedical Research Centre in the Mental Health and Technology team, and they've got a very strong PPI focus. So I think it's although we're the only secondary data research group, I think, within that, but it's very much encouraged and supported and seen as useful. As I say, I think it's other places. Recently did some work with some people in Australia, and in Australia they're beginning to sort of encourage patient and public involvement or consumer and community involvement there, but without the funders sort of necessarily supporting it. And I think they're a few years behind where perhaps there was more scepticism around PPI in general. And as I say, sometimes with CPRD study protocols that I review, people say, I'm not recruiting people, this is not necessary. And I write back, oh, I think there are plenty of opportunities where you could really benefit from speaking to people, even if it's just talking to a group and saying, this is our research question, this is our research topic. Is there anything that seems relevant?
Yeah, thank you. Yeah, I think it's a really important point about the funding as well, that realizing there are these opportunities and you can't shy away behind saying, oh, I don't have the money for this, because yeah, it's out there and we should be looking for it. Laura, do you want to go?
Yeah, thank you, Ruth and Debbie. That was really interesting. And what came across so strongly, I think, was the amount of time that you've both put in to developing the relationship that you've got now. And I really liked when Debbie was saying, you know, it wasn't just about what Ruth could get from the public contributors, it was also what Debbie's needs were in terms of what she wanted to get out of being involved in the research. So that was really, really nice to hear. And I just wonder if you could reflect a little bit on, you know, sort of how long it takes to develop those like sometimes I think people, you know, they're developing a fellowship and they want to have a single PPI meeting, and you know, and it always strikes me that, you know, you need that time really to get that relationship and to get that kind of effective working between both of you. I just wondered if you could comment on that.
I think for me, it's about right from the very beginning about being open and transparent with what the researchers' aims are, but also what the PPI aims are, and coming to some sort of middle ground where you know that you can ask those questions. Because at the beginning, with this one especially, I wasn't confident at all around what quantitative research was. It was all very, very new to me, and I found that because Ruth and everybody else was so open that they were willing to learn from us, and I was very willing to learn from them. And I think that's why the relationship is still there and still ongoing, because once you have that open and transparency communication, you're not going to get those bits where people think, well, you know, I didn't want to do that, or that wasn't why I did that, or the researchers maybe didn't want you involved in that part, and then that's where misunderstandings happen. So I think it is just basic communication and being open about what you can do and what you want to achieve and how you're going to achieve it.
I mean, I think certainly at the beginning, so Debbie was already involved in the project before I joined the team. And when we had our project meetings, then sort of afterwards, Debbie and I would go for a cup of tea in the cafe and sort of talk about me saying, well, how do you get involved in these studies? She's like, I've not done them before. So like, okay. So we're sort of learning together, which I think did help as well. But yeah, just that sort of constant communication and, you know, determining how often and in what format people wanted to be communicated with. So the other public contributor member who's part of our team, you know, we do online calls with them, and Debbie tends to prefer to come face to face, which is why we're in that little room together today. Just sort of, yeah, understanding what people want and how they want to contribute. So it does take time, but I think it's just sort of trying to keep that communication going as best you can.
Yeah, and I think I've learned an awful lot over the years. Like I said, I've been doing PPI work for a long time, but I've learned an awful lot about not only about research, but also about myself and about how I can ask questions and having that confidence to ask questions, and then developing my own relationship with other PPI members and enabling them to be able to ask and ask the questions that they want to ask, basically. So I think for me, it's been a massive learning curve, but also it's given me that confidence to be involved that bit more.
Great, thank you, and congratulations on the conference presentation. It looked a very grand environment to be giving a presentation in. So well done.
It was like Hogwarts.
Yeah.
Thanks, Laura. Justin?
Presentation. One of the things that I look at as well is that when it comes to people that turn around and say we don't need to see public involvement in this, it's okay putting a comment in like that, but when you have public reviewers sitting on the review panel and you put a comment in like that, that then makes them look at the public aspects of the summary in a lot more detail, such as the plain English summary and such things like that. So I always advise people to think very carefully when you put that sort of comment in, because is it something that's actually going to do your actual project any justice? Because the public reviewers will look at that, and if you put that in and they say an awful plain English summary or something like that, then they're going to, one of the comments will be as well, you did need public contributors to pick up on that to help you with the plain English summary and like things like dissemination and stuff like that. But also one of the other thing that I advise is that have public contributors right at the beginning, because even if they don't do anything initially, there's something there that somewhere along the lines that they learn the whole aspect of the project. Don't bring them in halfway through and say, look at this project, we've already done this work on it, because that's not a very good way of setting the scene for things, and that will also get picked up on a review panel level by people like me.
Yeah, I think as Debbie said, you know, sort of having that expectation set out from the beginning and sort of saying there will be a period where, you know, we're just going to be doing some analysis and we will meet with you and sort of say, this is how far we've got, maybe give you an example of the sort of stuff that we've done, but not just, you know, talk to people at the beginning and then 8 months later come back and go, hi, remember us, here's our results, can you help us now? Because that's not really engagement, and these people are busy and probably doing lots of other things and won't remember your project. So I think that communication, that setting of expectations and trying to have a relationship throughout the study is really important.
Thank you. Gulnaz?
Hi. Oh, can you? I have to put my camera on, it's not working. A great presentation, thank you both. I'm just wondering now, you know, when this project's come to an end, how would you build on this collaboration that you know you've forged together? What are the next steps? What's next? What's in the future?
Well, so as I mentioned, we're funded by the Biomedical Research Centre Mental Health and Technology theme, which is actually a sort of around 5 years, and we have our broad questions within that, but then we often sort of go off and do sort of aligned side projects, like the medication review sort of fitted in with the polypharmacy theme, but we sort of had this extra bit. So I think we're constantly looking for, you know, we have our fairly long term, which obviously really helps with that relationship building funding, but then getting these extra projects around, you know, polypharmacy and co-prescribing is really the area that we're focusing on. So lots of different things within that sphere continuing for the next couple of years at least, hopefully.
Oh, fantastic! Because there's always that danger, isn't it, where you get people saying it's quite tokenistic, and then when you come to the end of the project, they're kind of left with nothing to you know, go forward with.
I found through my experience of working on lots of projects that question comes up almost every time. And my sort of take on it is that right at the very beginning of the project, you work out what you're going to do at the end. And it may be that, okay, you cannot do a project that you would want to do with the same members, because people want different experiences. But I guess what I'm trying to say is there are opportunities that come up throughout the research that people can also get involved in. And I think if you're genuinely working together, there are opportunities that do come up where you can bring in your PPI group in to carry on doing what they do. And I've been very lucky in what I've been able to achieve to a point. I mean, I'm 68 in a couple of weeks, and I still want to do a degree because I now understand about research, because when I was younger, I wasn't able to go to university. So it's given me that, from coming from a point of view where I had no idea what research was. My take on research right at the very beginning was like, you see these people in the city centre with clipboards doing a bit of research, but now I know very much that was market research, and what you guys do is important research. And so fingers crossed one day I will achieve my dream, and that's through hard work, working together with researchers.
As Laura says, good luck. Go for it, Debbie.
Thank you.
If I can't see any other questions in the chat, Laura has put a link to the animation that you have shared. So if anyone wants to check that out or share it with their colleagues, then please do. And I've also put a link in for the website where this and the other seminars will get uploaded. So check that out as well. But yeah, if there are no final questions, then I'll just lastly highlight the next seminar we've got coming up is on Tuesday, the 8th of July. Where Ellen and Nikki from the University of Sheffield will be talking about their lessons from the Sheffield PPIE methodology panel. So hopefully we'll see a lot of you there. But yeah, just one final time, thank you very much to Ruth and Debbie for presenting a really, really interesting talk today. Thank you both.
Thank you. Thank you very much.